Hi, good morning, and welcome to Grand Rounds. It's really lovely to have all of you here. And we're delighted to have Dr. Adil Shujaat with us today. He is an associate professor of medicine in the Department of Medicine at Icahn School of Medicine at Mount Sinai, and he is the director of the Inpatient Pulmonary Service here at Mount Sinai West. You know, I think organizations, a sign of their health is their capacity to certainly retain excellence and find paths for faculty and trainees to remain in an institution for a long time. And recognizing excellence and people's capacity to do more and more is really an indication, I think, over time of an organization's fundamental ability to live in a way that is fostering of creativity and excellence and personal health and certainly professional development as well. And it's also important for all of us because we're all continually in the mode of recruiting. We're always recruiting, and that's one of the sort of the hallmarks of my career. It took me a while to kind of wake up to the fact that no matter what you're doing in medicine, you're always thinking about how can we invite others to join us, or how can we hold on to people that we recognize as being just that, high potential people that we want to remain in the family. And in that context, it's a challenge for all of us to maintain our networks, our professional networks, and then we're holding on to people. And one of the hallmarks, I think, of Hassan Cooley's career is he did just that. Hassan, throughout his career, has always maintained a robust network. And it was in this context, it was so delightful to know that Hassan had maintained contact with Dr. Shujaat and was inviting him back to join us. And that's because he trained with us. He did his residency in our internal medicine program, Dr. Shujaat, and then completed his pulmonary critical care and sleep medicine fellowship with us as well. Subsequently, he was in Florida at the University of Florida at Jacksonville, and then at the University of Buffalo. And again, we were so delighted to bring him back into the family because of everything that he is. His areas of interest have been hypertension, pulmonary hypertension, vascular diseases of the lungs, as well as pleural diseases. And one of the things that was fun for me to remind myself about in reviewing his CV is the particular focus he's had on limiting risk, limiting cost, asking hard questions about who needs what study and why. So, for example, who needs a spiral CT when they're in the emergency room and they think they might have a pulmonary embolus? Who's the right candidate for thrombolysis and who isn't? And why is it important for us to be thinking in those ways as we move forward in caring for our patients? Here at Mount Sinai West, Dr. Shujaat's already done wonderful work in developing our pleural program here and also being a champion for our PERT program. For anyone who doesn't know what PERT is, it's a pulmonary embolus response team. And it's a way to bring to bear excellence and expertise in the context of patients when they are acutely diagnosed with a pulmonary embolus and make sure they're getting the care that they need. Adil, it's really wonderful to have you back. It's wonderful to have you here, and welcome.
Thank you for the generous introduction. Good morning, everybody. So the history of medicine is fascinating, and the history of circulation is no exception. Ibn al-Nafis, the Syrian physician in the 13th century, was the first who described accurately the pulmonary circulation. Until then, Galen's belief had held for over a millennium. And this slide shows on the left-hand side what his beliefs were, and on the right-hand side what our current understanding of the cardiovascular system is. He believed that the concoction from food was transported to the liver, where it was imbued with the natural spirit and blood was formed. And it was then transported to the right ventricle, which pumped it to nourish the lungs. And through pores in the interventricular septum, it was passed into the left ventricle, where it mixed with air that was inhaled. And that vital spirit was distributed to the body. And some of it went to the brain, where the animal spirit was then distributed through hollow nerves to the whole body. Now, this idea of there being invisible pores was important to perpetuate this understanding. But Ibn al-Nafis was the first to describe that blood had to go through the lungs, and the lungs played a more important role. Please excuse my attempt at PowerPoint. Anatomically speaking, the heart is situated between the two lungs. But physiologically speaking, the lungs are between the two sides of the heart. And the right side of the heart pumps blood via the pulmonary arteries into the lungs, and from the lungs, blood is drained via the pulmonary veins into the left side of the heart, which is then going to pump blood to the entire body. Now, if I were to indulge you in a little bit of math here, as extrapolated from Ohm's law, the transpulmonary gradient of blood flow across the lungs is equal to the cardiac output of the right ventricle through the lungs flow and resistance offered by the pulmonary vasculature. And this gradient is the difference between the mean pulmonary artery pressure and the left heart filling pressure, whether it's measured as a wedge pressure or an actual LV and diastolic pressure. And if you were to rearrange the equation, it becomes easy to understand that mean pulmonary artery pressure is the product of cardiac output and pulmonary vascular resistance added to the wedge pressure. And this pressure may go up when any one or more of these three components is affected. Pathophysiologically speaking, starting from the left side of the heart and working our way more proximally, we have post-capillary pulmonary hypertension. The left heart, it's muscular because it's a pump that is going to pump blood to the entire body, and it has valves. The pump may be weak or it may be too stiff to accommodate enough blood to pump enough blood, known respectively as heart failure with reduced and preserved ejection fractions. And the valves may be affected because they're too narrow or they're too incompetent. So a rise in pulmonary artery wedge pressure is found in disease of the left side of the heart. More proximally, you have the respiratory system, which is made up of the evil of OSA, COPD, ILD, and OHS. And it's not that COPD only affects the right lung and ILD the left lung, it's just conceptually and helpful to remember. More proximally, you have the pulmonary arteries, where clots that may be residual and become organized can reduce the available surface area for blood flow and result in the condition called CTEPH, chronic thromboembolic pulmonary hypertension. Or the pulmonary arteries themselves can become diseased and the vessels become narrowed or obliterated, and that entity is called pulmonary arterial hypertension. And all of these affect the pulmonary vascular resistance. And last of all, if there is a condition that results in an increase in cardiac output, like anemia or morbid obesity or a left to right cardiac or extracardiac shunt, that will also result in an increase in mean pulmonary artery pressure and pulmonary hypertension. So to put it in two classifications, pulmonary hypertension, as defined by right heart catheterization at rest, is a mean PA pressure of 25 or greater. And if the wedge pressure happens to be 15 or less, it is pre-capillary. And if it is greater than 15, it's post-capillary. And the World Health Organization classifies these two hemodynamic categories into groups. Group 1 is pulmonary arterial hypertension. Group 4 is CTEPH. Group 3 is pulmonary hypertension secondary to lung disease and sleep disordered breathing. Group 2 is secondary to left heart disease. And Group 5 comprises pulmonary hypertension with unclear and or multifactorial mechanisms. So how prevalent are these different kinds of pulmonary hypertension? I like to say that the most common cause of pulmonary hypertension is left heart disease. The second most common cause is left heart disease, and the third most common cause is left heart disease. Makes up 80% of the causes of pulmonary hypertension. PAH, for which there is a $1 trillion pharmaceutical industry, actually constitutes only 2.3% of cases of pulmonary hypertension. CTEPH is even rarer with 0.6%. So what is pulmonary arterial hypertension? It's an arteriopathy, and it develops in those with risk factors or associated conditions or genetic predisposition. Associated risk factors and conditions may be connective tissue disease, HIV, portal hypertension, drugs and toxins, and the most commonly known genetic mutation is the BMPR2 mutation. This results in a vascular injury, and there's endothelial dysfunction resulting in an imbalance of vasoactive mediators, where there is an abundance of vasoconstrictors. And it's not just vasoconstriction, but also proliferation. So you can see that pathophysiologically, the smooth muscle undergoes hypertrophy and the intima starts proliferating. And as the disease progresses, there are vessels that become narrower and some are obliterated, and at places you may see plexiform lesions. These are thought to be possibly from bronchopulmonary anastomoses. And the mediators that play the most important role are nitric oxide, prostaglandins, and endothelin. So nitric oxide is one of the most powerful vasodilators. So is prostacyclin, and endothelin is one of the most powerful vasoconstrictors and proliferator. So how common is pulmonary arterial hypertension? It is a rare disease, and its prevalence is 15 per million adults. And the idiopathic kind, formerly known as primary pulmonary hypertension, is seen in approximately 6 per million adults. Idiopathic, heritable, and drug-induced PAH constitute 50% of PAH. And connective tissue disease, mainly systemic sclerosis, is the most common associated PAH. And the prevalence of PAH in the associated conditions is 5 to 12% in systemic sclerosis, 1 to 5% in portal hypertension, and 0.46% in HIV. There are certain drugs and toxins. Some have a causal association, others possible association, and the diet suppressants are the most well described. And the original NIH registry back in the 80s had a mini epidemic of cases that made up that registry. So how does a patient with PAH present? Most of them are young. They're 45 to 55 years of age, and it affects predominantly women. The ratio 3 to 1. And there are non-specific symptoms that can be seen from any cardiopulmonary disease. Dyspnea and exertion, ankle edema, dry cough, and exercise-induced nausea, sometimes frank vomiting when there's hepatic congestion, because blood cannot be forced forward into the lungs, so it backs up in the liver. And there are some unusual symptoms: hoarseness, wheezes, angina, that are from mechanical complications when the pulmonary artery becomes humongous and it stretches the recurrent laryngeal nerve. And they say a picture is worth 1,000 words, so let's look at this CT scan and coronary angiography pictures explaining how you can have angina from compression of the left main coronary artery by a humongous pulmonary artery that is more than 4 centimeters on a CT scan. So you can see the left main coming out of the root of the aorta, and this is the pulmonary artery pressing against it. And this is how narrow it is on coronary angiography, and this is after it has been stented. And there may be some symptoms of underlying disease: crest, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. What are the signs of pulmonary hypertension? Right heart failure. I'm sure everybody's familiar with it. Right heart heave, loud P2, and an S3 gallop. that's right-sided, a pansystolic murmur from tricuspid regurgitant. In extreme cases, an early diastolic murmur from a regurgitant pulmonary valve. Jugular venous distension, hepatomegaly, ascites, and edema. And then there are signs of an underlying cause, crest or cirrhosis, and clubbing is common to cirrhosis and Eisenmenger, except one patient's yellow and the other is blue. WHO Group 2, pulmonary hypertension secondary left heart disease may result from systolic or diastolic dysfunction or from valvular heart disease, and it is extremely common. Most of the patients eventually develop pulmonary hypertension, and it may be seen in 100% of patients with mitral valve disease when left untreated. So I'm going to return to this equation and refer to it again and again. When left untreated, the elevated left heart filling pressures results in an increased wedge pressure that will cause a passive pulmonary venous hypertension. But eventually, the endothelial dysfunction, together with unknown genetic risk factors or environmental risk factors or non-cardiac risk factors, comorbidities like COPD, OSA, ILD, chronic PEs, and chronic kidney disease, adds insult to injury, and the vessels start undergoing a vascular remodeling, and the hemodynamic profile changes from an isolated post-capillary passive venous hypertension to combined post and pre-capillary reactive pulmonary arterial hypertension-like profile, where the pulmonary vascular resistance is also increased to more than what is normally considered 3 Wood units as the cutoff. Group 3 is pulmonary hypertension secondary to lung disease and or hypoxia, and most commonly these are COPD, ILD, OSA, and obesity hypoventilation syndrome. How common is this? Very common. PH is common in severe COPD and ILD, but it is mild. Severe PH is uncommon. On the other hand, in OHS, PH may be severe, but it's partly from the high cardiac output required to meet the demands of adipose tissue. Here is a diagram explaining the pathophysiology behind pulmonary hypertension and COPD. So hyperinflation results in autopeep and an increase in the pleural and juxtacardiac pressures, which are transmitted to the pulmonary arteries and veins, and there is a direct increase in those pressures. Moreover, hypoxic pulmonary vasoconstriction, vascular remodeling, polycythemia, destruction of vascular bed, and compression of the alveolar vessels will result directly in increased pulmonary vascular resistance. WHO Group 4, CTEPH, chronic thromboembolic pulmonary hypertension, and other pulmonary artery obstructions, which are rare, angiosarcoma and arteritis, to name a few. And how common is this? 3.2 per million adults, and it's seen in as many as 4% of cases after an acute PE, and that's as much as you will see after 2 years, and it plateaus subsequently. And there are associated conditions. 32% of patients with CTEPH have a thrombophilia, and 3% of them have a history of having had their spleen removed. Group 5 is pulmonary hypertension with unclear or multifactorial mechanisms, or both, and they may include hematological disorders, systemic disorders, or other conditions. And sickle cell, which is a common hemolytic anemia, is included here, so are myeloproliferative disorders. To us, the most commonly encountered group 5 pulmonary hypertension is sarcoidosis. Pulmonary tumor thrombohyperangiopathy and chronic dialysis, kidney disease with dialysis or without dialysis are also multifactorial. And just to show how sarcoidosis can cause pulmonary hypertension, it can result in actual destruction of the pulmonary vascular bed or cause hypoxic pulmonary vasoconstriction. The pulmonary arteries may be compressed by enlarged lymph nodes or mediastinal fibrosis. There is a pulmonary vascular phenotype. Patients with sarcoidosis are at higher risk of pulmonary embolism. Liver involvement may result in portal hypertension and that causing portal pulmonary hypertension. Myocardial involvement may cause left heart dysfunction, and then patients with sarcoidosis are also at higher risk of obstructive sleep apnea. So trying to figure out which of these causes is playing a role and treating it is the way to go in sarcoidosis-associated pulmonary hypertension. Now, putting it all together, so you have a person in whom symptoms and signs and history is suggestive of pulmonary hypertension. The next step is an echocardiogram, and it will show if they have pulmonary hypertension or not. And if they have pulmonary hypertension, then considering heart and lung diseases are the common causes, you look into confirming that possibility by doing EKG, and PFT, and DLCO, chest X-ray, and if necessary, a high-resolution CT scan. So echocardiogram will be helpful in telling you if there is heart failure with a reduced ejection fraction or valvular disease. And it's more difficult to grasp the concept of preserved ejection fraction and yet having left heart failure. Moreover, echo is not foolproof, and there are variables that affect measurement of the systolic PA pressure. So everybody has a certain degree of tricuspid regurgitation, and that's what is examined to measure the gradient across the tricuspid valve. And that gradient across the tricuspid valve is equal to 4 multiplied by the square of peak TR jet velocity. And rearranging this equation shows that this, together with the right atrial pressure, gives us the RV systolic pressure. And provided there's no RV outflow tract obstruction, it approximates the PA systolic pressure. And a cutoff of 40 defines pH by echo. So how do you measure the RAP? Depends on what method you use, whether you're looking at how much the IVC collapses or not with respiration, or you actually measure the JVP, or if there is a central venous line in place. And if the TR jet velocity is not accurately measured, and that's going to be squared and then multiplied by 4, you can see how one person may go from having PH to not having PH in right heart cath, or vice versa. Despite that, it has a modest sensitivity of 83% based on a meta-analysis of studies looking at the diagnostic accuracy of transthoracic echocardiography. What about CT scan, which have become so common? On a CT scan, looking at the diameter of the pulmonary artery and comparing it to the diameter of the aorta can tell you if a person has a high probability of pulmonary hypertension. And a ratio of greater than 1 indicates pulmonary hypertension with a sensitivity of 74% and specificity of 83%. And this is meta-analysis that I did with one of the residents, Natasha Garg, who's going on to start her fellowship here and will be presenting at the ATS in May. So the two appear to be complementary. And if they're complementary, what is the diagnostic accuracy of the two combined? If we look at just the TR jet velocity, not looking at the systolic PA pressure and making it more inaccurate, and the ratio of the pulmonary artery to aorta being greater than 1, then the sensitivity approaches 98% and makes for an excellent screening test to exclude pulmonary hypertension where your probability is intermediate to low to begin with. So this summarizes the diagnostic accuracy and shows the two tests are complementary, and the combination of two can virtually exclude pulmonary hypertension with those in whom the probability is low to intermediate. So how does WHO Group 1 PAH compare to Group 2, heart failure from left side? Their clinical features, radiologic features, EKG, and transthoracic echo. So there may be history of having used anorexigens. They may have an associated condition. Whereas patients with left heart disease are older, suffer from metabolic syndrome, may have coronary disease, AFib, and complain of orthopnea and nocturnal episodes of dyspnea. and on exercise, there may be an unusually high blood pressure. Chest X-ray will show that the central parts of the pulmonary arteries are enlarged and peripherally they're pruned because they're narrowed and obliterated. Whereas in left heart disease, you'll see curly B lines, pulmonary edema, pleural effusion, and an enlarged left atrium displaying the main bronchi. EKG consists of predominantly right-sided findings in PAH, whereas it's predominantly left-sided findings in left heart disease. So you have a chest X-ray here showing a pulmonary artery next to the bronchus intermedius and larger than its diameter, and peripherally there are no vascular markings, and on a lateral the RV is touching the sternum all the way up. The EKG will show right axis deviation, right ventricular hypertrophy, and signs of right heart strain and P. pulmonale. Echocardiography is the most common test used to distinguish the two based on the probability that you've already developed using history and exam. So this is precapillary and postcapillary pulmonary hypertension. So you see the right-sided chambers are larger than the left, and here it's the other way around. Then the left ventricle on cross-section is D-shaped because the septum is pushed into it as opposed to the left side retaining its circular ring-shaped appearance in left heart disease. IVC may be dilated and fixed or dilated and not move much with respiration. On the other hand, it's easily collapsible in left heart disease. And you have the ratio of the mitral flow velocity E and the early mitral annular tissue Doppler velocity E prime as an echocardiographic equivalent of your left heart filling pressure. And the magic number happens to be 15. So an E to E prime ratio of greater than 15 on an echo is saying the same thing as somebody's pulmonary artery wedge pressure is greater than 15, or their LV and diastolic pressure is greater than 15. So how does WHO Group 1 pulmonary arterial hypertension compared to pulmonary hypertension from lung diseases and or hypoxia? High-resolution CT will show that there are characteristic airway abnormalities and or parenchymal abnormalities. PFTs will show that lung function is more than modestly affected. FEV1 is less than 60% in COPD, and FVC is less than 70% in IPF. On the other hand, a person with COPD or IPF may also have pulmonary hypertension of the group 1 kind, which may be attributed to the lung disease itself. But if their lung function is mildly affected, then the lung function is not responsible for that arteriopathy. So an FEV1 of greater than 60% in a patient with COPD and pulmonary hypertension means it's not from the COPD. Likewise, in IPF, when its FVC is more than 70%, that's not the case. The pH is not from the lung disease. Cardiopulmonary exercise test will refine this, and there will be features of an exhausted circulatory reserve in case of PAH, as opposed to patients who have true pulmonary hypertension from and hypoxia, where there will be features of an exhausted ventilatory reserve. How does WHO Group 1 compare to Group 4, which is chronic thromboembolic pulmonary hypertension? On the CT scan, dilatation of bronchial arteries, which provide collateral blood flow, bypassing the narrowed obstructed pulmonary arteries, whether they be from PAH or CTEPH, is very common, 73% of such cases, as opposed to much less commonly seen in PAH. And a combination of mosaic attenuation and variation in size of segmental pulmonary arteries. Again, common in CTEPH, but less common in IPH. Thrombus itself is usually intraluminal webs and bands in central and peripheral pulmonary arteries in CTEPH, whereas rarely there may be an apposition thrombus seen in pulmonary arteries when they become so huge and blood flow through them is so sluggish that a layer of thrombus develops. Here are serial CT scans from a case showing a thrombus that has become organized and part of the wall of the right pulmonary artery. And here on the subsequent section, and the left one is plugged up with a large clot, And here lower down, you can make out a crescent of the organized clot, making the vessel itself much narrower than it originally was. And coincidentally, if you pay attention to the heart, you can make out the right atrium is the size of the patient's head, and the RV is pushing the septum into the LV, which is squished. So putting it all together, if you have made a diagnosis of left heart disease or lung disease, then the next step is pulmonary hypertension severe? Is there RV dysfunction? If there isn't any, then treat the underlying disease. If there is severe pulmonary hypertension and RV dysfunction, even if the person has heart disease or lung disease, then you should refer them to a PH expert center. On the other hand, if a person has neither left heart disease nor lung disease, then you should do a BQ scan and look for the possibility of CTEPH. And if there are ventilation perfusion defects showing that there is CTEPH, then the next step would be to do a CT pulmonary angiography. On the other hand, if there are no clots on BQ scan and you've screened out the possibility of CTEPH, then PAH is likely, and you should do specific diagnostic tests, which would be connective tissue disease serologies, hepatitis B and C serologies, HIV, and in some cases BMPR2 mutation testing. And in a case of CTEPH, you should consider thrombophilia workup. Cardiac catheterization. History was made here in New York City in Bellevue by Columbia's First Division back in the 40s, when the Frenchman André Cournand and the American Dickinson Richards pioneered cardiac catheterization and refined the technique and were awarded the Nobel Prize in Medicine. When do you perform a right heart catheterization? In PAH and CTEPH, to confirm the diagnosis, to guide treatment in PAH, which will include vasoreactivity testing, and in pulmonary hypertension secondary to left heart or lung disease, you should consider it if a heart or lung transplant is being considered. And you should also consider it if PAH is severe or RV dysfunction is seen on echocardiography. And the right heart catheterization allows you to measure not only the pressures in the chambers and the wedge pressure and the LV and diastolic pressure may be required sometimes, but also the cardiac output more accurately. And pulmonary vascular resistance, which defines pulmonary arteriopathy, can only be calculated if you have these parameters, the mean PA pressure minus the pulmonary arterial wedge pressure, that gradient divided by the cardiac output. And oxyhemoglobin saturation will tell you if there's a step up when the saturation goes up when you're entering the right atrium because there is an ASD and blood's coming from the left side, or when you're entering the RV and there's a BSD and blood's entering from the left to the right and there's a step up in the saturation. What is vasoreactivity testing? This testing is done to determine who will benefit from calcium channel blockers, so that the insurance companies are spared having to prescribe and cover the extremely expensive PAH-specific medicines that I will talk about. It's in idiopathic, heritable, and drug or toxin-induced PAH that this testing should be done. And only 10% of patients with such PAH are responders. And the honeymoon period is over in 1 to 2 years. So they're not going to last that long. A positive response is defined by a decrease in mean PA pressure by 10 or more to 40 or less with an increased or unchanged cardiac output. And the most commonly used agent is inhaled nitric oxide, 10 to 20 parts per million for a 5-minute period, that's it. IV epoprostenol, Flolan, is an alternative. And sometimes when the diagnosis of heart failure with preserved ejection fraction is in doubt, so provocative testing may be required, where a wedge pressure may be on the fence, maybe it's 16, maybe it's 14, and they're in their 60s, the metabolic syndrome, and you're wondering if they have left heart disease or true PAH. And you may, depending on what the pretest probability is, resort to actually exercising them, giving them a volume challenge or nitric oxide, and seeing what happens to the wedge pressure. If that remains high or worsens, then it's heart failure. On the other hand, if you have a patient who's also hypertensive and you give them nitroglycerin or nitroprusside and their wedge pressure comes down and it brings down the pulmonary pressure and PVR, then it's heart failure with preserved ejection fraction. So the right heart catheterization is important to try to accurately determine what exactly is the underlying hemodynamic profile. So when do you perform a left heart catheterization in coronary angiography, not just a right heart catheterization? When you're interested in measuring the LV-EDP, or if there are symptoms of angina and the risk factors for coronary disease. And if you're planning on pulmonary thromboendarterectomy for CTEPH or a lung transplantation. So PAH is pulmonary hypertension with a wedge pressure of 15 or less and no other cause of pulmonary hypertension. No cardiac disease, no respiratory disease, no blood clots. Essentially a diagnosis of exclusion. And what is its natural course? Progressive till it kills the patient. PVR will continue to rise. And pulmonary artery pressure will increase. There will come a time when the patient starts becoming decompensated and the cardiac output starts falling. And when the cardiac output starts falling, then the pulmonary artery pressure will also start falling. So do not be misled by thinking that if serial echocardiography is showing pulmonary artery pressure is improving, you have to treat the patient, not the number. Once a diagnosis of pulmonary arterial hypertension is made, we risk stratify patients into low, intermediate, or high risk of death or decompensation based on progression of symptoms, including syncope, signs of right heart failure, the World Health Organization functional class, 6-minute walk distance, cardiopulmonary exercise test, PN peptide, transthoracic echo, with or without a cardiac MRI, and a right heart catheterization to decide on how to treat them. This is the simplest way of describing the WHO functional class. 1, 2, 3, 4. Symptoms with extraordinary activity, ordinary activity, less than ordinary activity, and symptoms at rest. And what are the symptoms? Dyspnea, fatigue, chest pain, or near syncope. So what is the treatment approach in PAH? There are general measures, supportive therapy, specific therapy, and when all else fails, lung transplantation. The most important one in women is to avoid becoming pregnant, because the increased blood volume associated with pregnancy will not be handled by the right side of the heart. Immunization, any infection and sepsis with its increased metabolic demands cannot be met by a heart which is limited and it's reserved by pulmonary hypertension. And these are young patients who may have their life shortened when given such a diagnosis. So a lot of psychosocial support is required. And some of them may require oxygen, intravenous pumps and medication. And so a lot of support is needed in that regard. We shouldn't tell them to just stop exercising because they'll pass out from low cardiac output, but there should be supervised exercise training. And when they travel by air, in-flight oxygen should be provided to those with even modest hypoxia. And if elective surgery is required, an epidural is preferred to a general anesthesia. Supportive therapy comprises oxygen in those who are modestly hypoxic, diuretics in those with right heart failure and hypervolemia, anticoagulation in those with idiopathic, heritable, and dragotoxin-induced PH, and those who are on intravenous flow lag, so that the catheter through which the medicine is running will not clot. Correction of anemia or iron status or both, and treatment of any abnormal thyroid function and and sleep apnea. PAH-specific therapy. Robin Barst spent her career at Columbia, where she was Professor Emeritus until she passed away a few years ago, and was a pioneer in the field of drug therapy, and was the lead author on the 1995 NEJM publication of the first randomized controlled trial of what was the only medicine available back then, Flolan, and for the next several years. We've come a long way from 1995 to now, and there is an abundance of medicines. Following the first trial, the first oral medicine became available in 2001, bosentan, and then a decade following Flolan, sildenafil was found to work in pulmonary hypertension. Who knew that ED and PH had something in common? The medicine, of course, had to be marketed under a different name. Instead of Viagra, it was labeled as Rebatio. These are the three different pathways that are implicated in the development of pulmonary hypertension. You have the endothelin, nitric oxide, and prostacyclin, and this is where the different classes of medicines work. The ERA, endothelin receptor antagonist, and the SGC simulator, and PDE5 inhibitors, and prostacyclin or prostacyclin agonist. And these are the medicines bosentan, ambrisentan, macitentan, sildenafil, and tadalafil, riociguat, and among the prostacyclins and their analogs, epoprostenol is the most well-known. Iloprost is inhaled. Treprostinil is available in a variety of forms, whether you want to inject it into the veins, the skin, or inhale it, or give it orally. It's just not available as an enema. That won't work. Although back then, CPR was done that way, but we'll not talk about that. Selexipag is the newest medicine. So let's talk about these different medicines briefly on one slide. That's all I'm going to give them. Calcium channel blockers in high doses. I mean constipating doses. Nifedipine, diltiazem. Can you imagine 720 milligrams of diltiazem? You start low and you go up slow. And please don't use it if somebody is already in heart failure, because they're negative inotropes. Endothelin receptor antagonists are highly teratogenic, and patients are advised to exercise two forms of contraception. Bosentan can cause abnormal LFTs, so monthly LFTs are required. Ambrisentan may cause edema. Yes, that's like when you watch an ad on television and it tells you Prilosec may cause indigestion. Why am I taking it in the first place? Macitentan may cause anemia. Nitric oxide pathway, you have PDE5-1, rarely can cause blindness. Concomitant use of nitrates can cause a profound hypotension. So you've got to stop those if for one or another reason they were also taking it. Prostacyclin analogs, Flolan has an extremely short half-life, only 3 to 5 minutes, and it's stable at room temperature for only 8 hours. Now there is, thank God, a room temperature stable formulation available. Their side effects are well known: flushing, jaw pain, headache, diarrhea, local pain, and those who have intravenous continuous infusion of pump malfunction may be fatal by causing rebound pulmonary hypertension. And of course, there are always risks of catheter-related bloodstream infection and thrombosis in anybody who has a catheter in place. Randomized controlled trials in pulmonary arterial hypertension have evolved in the 2 decades since the study of Flolan. And the endpoint has improved from the surrogate 6-minute walk distance to now a composite of clinical outcomes. And there are more and more patients who are on already background therapy. And the number of PH expert centers has gone up from 12 to more than 60 in the United States alone. And there have been a number of medicines that have become available nowadays. So these are the original short-lived trials that helped all of these medicines get FDA approved, because they showed an improvement in 6-minute walk distance. But an improvement in 6-minute walk distance may not help a patient live longer, it turns out. So more recent trials have been larger, longer, and necessary because these drugs also had to find a niche in the market. So what better way of selling a drug than saying, we actually save lives? So what are the different outcomes that are used in the most recent morbidity and mortality trials? There may be worsening pH based on worsening 6-minute walk distance, worsening symptoms, hospitalization, or the need to start intravenous or sub-Q prostacyclin analogs, lung transplantation or its bridge, balloon atrial septostomy, and of course all-cause death. So whether it's Seraphim, Griffin, or Ambition, any of these 3 trials, they all had more or less the same composite of endpoints. And you'll see the hazard ratio is showing a 50 to almost 50% reduction in the event rate. Here is Seraphim showing macitentan at the high dose compared to placebo over the course of 36 months, 3 years. And here is Griffin showing oral selexipag compared to placebo with a hazard ratio showing 40% reduction. And then you have Ambition, a combination of ambrisentan and tadalafil showing a 50% reduction too. But when drugs fail, what should we do? Lung transplantation. This is James Hardy, chair of surgery at the University of Mississippi Medical Center, who in the 60s made history by performing the first successful lung transplant. The patient lived 18 years. The event was overshadowed by the death of a civil rights activist on the same day who had come in with a gunshot wound in the OR next door. But next year, history was made when he transplanted a chimpanzee's heart into a human. So lung transplantation took another 20 years to be refined and become a safe enough procedure. When you're going to transplant an organ where everything you inhale is going to enter, and then you'll be on immunosuppressants. It's been tough. But fewer and fewer patients now undergo lung transplantation for PAH because of the availability of so many drugs. And it's the lungs that need to be transplanted, not the heart, because the disease is in the blood vessels in the lungs. Once the lungs are transplanted, the pulmonary vascular resistance returns to normal, the RV starts undergoing a reversal of the hypertrophy and is no longer dilated and goes back to working well. So this is the treatment algorithm in PAH. So PAH is confirmed by expert center. There's an acute vasoreactivity testing done in those who require it, and if they're vasoreactive, calcium channel blockers are started. Those who are not, depending on their risk profile, as I discussed, taking all those variables into account, if it's low or intermediate, you may start with 1 or 2 oral medicines, and if they have a high risk of death or decompensation, then you start with a combination that includes intravenous medicines. If the response remains inadequate, inadequate means that you're still unable to achieve or maintain a low risk profile, then you should go on to double or triple sequential combination. And if that fails, then you should consider lung transplantation. Or you should consider that at an earlier stage, so you start listing the patient. Now a few slides about the remaining PAH. Pulmonary hypertension secondary to left heart disease or lung disease. The saying is always treat the heart or treat the lungs. So you have to optimize treatment of the underlying disease, optimize volume status with diuretics, and in case of lung diseases or OHS, optimize gas exchange with oxygen or if necessary non-invasive ventilation. And screen for other causes of pulmonary hypertension and treat them. And consider right heart catheterization if you're planning on transplanting the heart or the lungs, or if there is severe PH or RV dysfunction or both. And if there is, then you should refer those to a PH expert. You should avoid PH-specific therapy in those with less severe PH. Why? Because in left heart disease, you'll be literally opening the floodgates. So here are diagrams showing the right and the left heart in series, with the left atrium transmitting pressure into the lungs and the pulmonary arteries, and this is the compliance curve for the left atrium. As the LV becomes stiffer and the LA becomes large and stiffer, pressure is transmitted into the pulmonary capillaries, and that's transmitted into the pulmonary arteries and RV. So if you were to give nitroprusside and bring down the afterload, then on the other hand, if you were to give inhaled nitric oxide or other pulmonary arterial hypertension specific therapy, then it'll open the pulmonary arteries, more blood will flow forward, but the bottleneck is here in the left heart, and that will flood the lungs. This is an implantable pressure monitor, CardioMEMS, that you can see is barely over a centimeter in length and is placed in one or the other pulmonary artery, and it allows the pulmonary artery pressure to be monitored by the cardiologist, and guiding the patient's therapy to the PA pressure has resulted in a 50% reduction in hospitalizations for left heart failure. This was published in Lancet, and the champion investigators have subsequently published follow-up longer studies showing consistent benefit. Now, in lung diseases, ventilation perfusion mismatch may be worsened. So here is a two alveolus model, pulmonary arteries perfusing them and pulmonary veins draining them. If the lung is diseased, then the pulmonary arteries supplying that part of the lung undergo a hypoxic pulmonary vasoconstriction as a compensatory mechanism to divert blood away to the normal parts of the lung. And if you give a vasodilator, it'll undo the hypoxic pulmonary vasoconstriction, making blood flow through parts of the lung that are diseased and not picking up oxygen. So it makes the hypoxia worse. On the other hand, if you were to introduce an inhaled pulmonary arterial hypertension specific medicine, then it will actually go into the better part of the lung, open up these arteries more, not affect the other parts of the lung or their adjacent blood vessels, and you could improve not only the pulmonary vascular resistance, but also the gas exchange. And inhaled nitric oxide is available in hospitals as these large, portable, but impractical to use every day as an outpatient cylinders. This INO-Pulse device, barely 2.5 pounds, and in phase 3 trials at the moment to see if this, together with the use of oxygen, can, beyond improving pulmonary hypertension, improve other parameters, functional capacity, and more to come later as those trials evolve. So in pulmonary hypertension secondary to COPD, the approach is to contract hyperinflation, pulmonary vasoconstriction, pulmonary vascular remodeling, and polycythemia. So hyperinflation is best counteracted by pharmacologic lung volume reduction. You could have bronchoscopic or surgical lung volume reduction also. Oxygen is the strongest pulmonary vasodilator for these patients. Phlebotomy is required when they are polycythemic, and PAH-specific therapy rarely when pulmonary hypertension is severe. But before we go on to become trigger happy about prescribing medicine, non-invasive ventilation, even when the pulmonary hypertension is as severe as a mean PA pressure of 49, used with an IPAP to EPAP of 21/5, after 3 months can result in beautiful reduction in the mean PA pressure to 31, with an improvement in 6-minute walk distance from 303 to 384. So it works. So if you have COPD patients or OHS patients with hypercapnia and pulmonary hypertension, even if it's severe, this is the way to treat it. When everything else has failed or you've treated it to the best of your abilities and the person still has severe pulmonary hypertension, and you call it pulmonary hypertension out of proportion to left heart disease or COPD or ILD, then do these medicines have a role? So we use them on compassionate grounds. It's a non-FDA approved indication. There's one pilot study in heart failure with preserved ejection fraction of 44 patients from Italy where it showed significant improvement in pulmonary hemodynamics and quality of life with sildenafil. In COPD, we did a meta-analysis of 7 randomized trials that showed significant improvement in mean PA pressure and 6-minute walk distance. But the sample size, even for a meta-analysis, was too small to show an effect on cardiac index and PVR. There were no adverse effects because these patients have severe PH. So it's not just COPD causing PH, they actually have a pulmonary arteriopathy. In ILD, there's a meta-analysis that one of the residents will be presenting at the ATS. Of 208 patients, 50% of whom had IPF showed significant improvement in mean PA pressure, cardiac index, and PVR, but not 6-minute walk distance. Again, there were no adverse effects on gas exchange in these patients with severe PH. The last of all pulmonary hypertension, the virtually curable. Nina Brandwald is credited as having performed the first successful pulmonary thromboendarterectomy at UC San Diego. Yes, and for those of you who are cardiologists or becoming cardiologists, Eugene Brandwald is her husband. She moved to Boston to Harvard, and her colleagues carried out thromboendarterectomies. And to this day, it is the world's most renowned center, having performed the largest number of pulmonary thromboendarterectomies. Cardiopulmonary bypass, sternotomy, and these are called out, and you're cured. But not everybody is lucky. There are patients who are inoperable because the disease is too distant. And there are those in whom, even after removing the proximal clots, there is residual disease. So beyond lifelong anticoagulation, the treatment algorithm requires assessment of operability by a multidisciplinary CTEPH team. If it's technically operable and the risk-benefit ratio is acceptable, go ahead with it. If not, then you have to use PAH-specific therapy. And the only one approved by the FDA is Vasoreactivity, which the pharmaceutical industry needed a niche in the market to sell their drug. If there are persistent symptoms of pulmonary hypertension despite endarterectomy, then again PAH-specific therapy. If the patient is technically not operable, PAH-specific therapy. Balloon pulmonary angioplasty is rarely performed in the US. It's a well-known procedure in Japan. And last of all, lung transplantation, if everything else fails. So interventional treatment consists of balloon atrial septostomy. You puncture the atrium, creating a shunt. So the right side of the heart dumps its blood into the left side so that the cardiac output is preserved even if it's at the expense of hypoxia. Nobody dies of hypoxia. It's always the drop in blood flow. ECMO, right ventricular assist device. And for those in whom it's not urgently needed, they can proceed on to lung transplantation or a heart lung transplantation. Screening for pulmonary hypertension is an important part of medicine, especially in those disorders in which there is a high probability of this being found eventually, because patients may be limited by other symptoms in their functional capacity. Systemic sclerosis is one of the most important if you're considering organ transplantation, liver, heart, or lung, following an acute PE after 3 months. And those who have a BMPR2 mutation or first-degree relatives of patients with heritable pulmonary arterial hypertension. And with this last slide, I conclude my talk. Thank you for letting me go over time. We started a little later than usual. I'm happy to answer any questions you may have.
Waiting for Dr. Rod. Adil, thanks for a great talk.
Thank you.
I'm kind of delighted in seeing some of your early slides when you talked about findings like the heave, clouding of the retrosternal clear space, and what have you. And I'm curious if you could comment upon the sensitivity of those findings. And separate from that, in terms of screening for patients, when do you think it's appropriate to start?
Thank you for those questions. So the sensitivity of those radiologic findings and exam findings were modest to begin with, and unfortunately in today's day and age where 2/3 of the population of the Western Hemisphere has become obese or overweight, it's gone down even more. I don't know the exact numbers because I didn't care for them. So I'm sorry, I don't have the exact numbers. And you'd asked about
screening, when you start.
The screening protocol for diseases like systemic sclerosis should be at the time the person is diagnosed with the disease. And pulmonary hypertension itself is an indication for transplanting a lung or a heart in those with lung disease that is severe, COPD or IPF, or heart disease that is severe. And so if they're found to have pulmonary hypertension when they're periodically being followed up as part of their objective surveillance, in addition to their subjective improvement or lack thereof in symptoms and exercise tolerance. For liver, because in cirrhosis, the liver is preventing blood from the gut to go into the right side of the heart. When a liver is transplanted, all of a sudden you're opening the floodgates and there is a large bolus of portal blood going into the right side of the heart. So a patient with pulmonary hypertension will die on the operating table, and that was learned years ago. So now all of those patients with cirrhosis, particularly who are being considered for liver transplantation, should be screened for pulmonary hypertension. And if found to be severe and will not be able to handle the increase in venous return upon receiving the new liver, should have that treated, and their mean PA pressure should be brought down to less than 50 for them to safely undergo liver transplantation. Post-acute PE, there are a number of prediction models that we use in determining who among patients who have suffered an acute PE should be followed up. But David will disagree with me, and he will say that everybody who has suffered from a PE should be screened for CTEPH as early as 3 months following the episode. So we don't have good data, but unfortunately it's such a rare disease, post-acute PE 4%, that we don't have a large enough number of patients to know if we will, in the long run, even make any difference if we were to screen and find the disease.
Can I make a comment from St. Luke's?
Yes, thank you, Dr. Reno.
Yes, this was a splendid talk indeed. And on a historic note, I had my house staff training on the Columbia Division at Bellevue in the late 40s and early 50s. And that was a time, as you pointed out, when right heart catheterization was being used to evaluate patients in heart failure from COPD. And it was dramatic. Patients would come in markedly edematous, 20 and 30 pounds overweight, markedly hypoxic. They would be oxygenated, the pulmonary artery pressure would come down, they would diurese, and they would be restored to a reasonably functional state. It was dramatic, and it really was at that time a therapeutic breakthrough. And it was great to see it going on actually at the bedside on the wards at Bellevue.
It's amazing. Thank you for sharing your experience. And yes, there was the days of when it was a combined cardiopulmonary fellowship.
Hi, thank you so much for the talk. I just have a question regarding advising patients to avoid pregnancy with PAH. Are contraceptive pills still allowed, or is there a specific contraception that is contraindicated given the higher risk of venous thromboembolisms?
So thank you for asking. That's a good question. Yes, contraceptives are required and recommended, and a barrier method, in addition, is preferred. The class of medicines, endothelin receptor antagonists, are also teratogenic, so it's more important from that point of view as well. And of course, should one conceive, then they should be followed closely. But oral contraceptive pills are recommended, and as far as anticoagulation is concerned, we don't have good data on if everybody with group 1 pulmonary arterial hypertension should be routinely given anticoagulation. But we've moved on from the era of warfarin to now having new oral anticoagulants, directly working oral anticoagulants that are easy to comply with. And hopefully we will have data on if they should be used or not. But the mere high risk of VTE is not a contraindication to its to the use of oral contraceptives.
Thank you, Shujaat, for a wonderful, organized talk with the evolution from getting knowledge of circulation. I wanted to ask another question because I'm confused as to what to do. That is, in pulmonary thromboembolism, the initial recommendations were to treat for 3 months, and now that's extended to 6 months. But in finding CTEPH, chronic thromboembolism, is in 2 years, should we in fact do it longer than the 6 months? So that's question number 1, because I know it's a risk-benefit consideration and studies may be ongoing, I don't know yet. The other question is, how do other comorbidities alter your algorithms? Severe chronic renal disease patients on dialysis, does that change your approach to the analysis and the treatment?
Thank you for those wonderful questions. So for an acute PE, the guidelines recommend 3 months of therapy when there is a provoking factor, and for idiopathic, at least 3 months to indefinitely. One elegantly performed randomized controlled trial from Italy showed that patients benefited from warfarin as long as they were on it for 18 months. Following that, for 1.5 years that both groups were followed, the risk became similar in both the placebo group and those who had received 18 months of warfarin therapy. So indefinite anticoagulation following the initial 3 months required course. If those who have a high risk of major bleeding, or when the risk-benefit ratio no longer favors indefinite anticoagulation, then aspirin 100 milligrams a day. Yes, there's no such thing as 100 milligrams a day in the US, but the 2 randomized controlled trials published in NEJM come from Europe, is better than nothing. And your other question was about comorbidities, especially in those with multifactorial pulmonary hypertension. If we find any cause of pulmonary hypertension and we treat it and pulmonary hypertension persists, we then go on to pursue the possibility of them having a pulmonary arteriopathy that needs to be addressed as one would address PAH. And because there is a significant component of volume in cardiac output in determining the pulmonary artery pressures. So yes, you're right, a person with end-stage renal disease who's on dialysis, and since Medicare will only cover dialysis 3 times a week, even though some patients require more than that, and there's no scientific reason for them to be only dialyzed 3 times a week. Unfortunately, that's how the reimbursement was set. But here or there, they may be given extra sessions of dialysis by those centers on a charity basis, or where they know that it will prevent hospitalizations in such cases. One elegant study looked at using ultrasonography of the IBC during dialysis to determine when they had reached euvolemic status, and you could see respiratory variation in the IBC again, meaning that they were no longer hypervolemic, rather than approximating their dry weight based on the standard and age-old method. So that would be wonderful if we can find a way to optimize their volume status. Unfortunately, an AV fistula, by creating an increased cardiac output, also adds insult to injury. So sometimes if the flow through the fistula is larger than it should be, that may also require a revision to improve the person's pulmonary hypertension. So it has to be individualized to what you come down to finding out is the particular cause or mechanism of pulmonary hypertension.
Adil, thank you very much.
Thank you.